patients were given blood, screened blood, certified blood. They did not collapse immediately. There was no transfusion reaction, no fever, no hemolysis. Years later, the diagnosis came: HIV, hepatitis. The transfusion had happened long ago, inside one of India's most trusted hospitals. This episode of Blood Crimes is not about a fake blood bank. It is not about untrained staff in a remote clinic. It is about All India Institute of Medical Sciences, India's premier medical institution, and about what a series of real cases revealed: that even the best systems can fail, and when they do, blood becomes the perfect silent carrier. Over multiple years, patients, including children, were diagnosed with transfusion-transmitted infections. Families asked a simple question: how did this happen? Many patients had no risk factors, no history of unsafe injections, no other exposure. The common link was prior transfusion. These cases reached national newspapers, courts, government committees. This was not a rumor. This was documented, investigated, and debated publicly. How safe blood can still transmit infection. At the time of these transfusions, blood was screened, mandatory tests were done, reports were documented as negative. So what went wrong? The answer lies in limitations of screening, not absence of screening. Key factors: window period infections, sensitivity limits of older assays, high pressure, high volume blood banks, dependence on paperwork over traceability. A unit of blood can test negative and still be infectious. This is not theoretical. It is a known, documented risk. Why detection was delayed? Transfusion-transmitted infections rarely declare themselves immediately. HIV and hepatitis may take months or years to manifest, are often diagnosed far from the transfusion event by the time infection is detected. The blood unit is long gone. Donors are untraceable or unavailable. Records are archived. Responsibility becomes diffuse. For families, the link is obvious. For institutions, the link becomes unproven. This delay is what makes blood crimes invisible. When cases surfaced, hospitals denied causation. Alternative explanations were offered, legal battles followed. What mattered most was not intent, but accountability. No single person was accused. No single act was criminal. But the system had failed to prevent, failed to detect early, failed to communicate transparently. The cost was borne entirely by patients. Why this is a blood crime? This was not a surgical error. This was not malpractice in the traditional sense. This was a systemic blood safety failure. Blood was trusted, blood was certified, blood was transfused, and blood carried life-altering infection. The crime was not malicious intent. The crime was assumed safety. These cases forced reforms. They improved screening. They strengthened oversight. But they also proved something uncomfortable. Even in the best hospitals, blood can fail silently. And when silence replaces accountability, harm continues without resistance. Silence has consequences. This is Blood Crimes.